All right, now we are officially recording for anyone who can't make it over this lunch hour. All right, well, thank you all for being here. I see the internet is doing its magic because I see the attendees coming in. Yay! I'm going to introduce my special guest here, and then give some housekeeping. Well, if I haven't connected with you, my name is Steph Wagner. I am a registered dietitian. I've specialized in bariatric surgery and now GLP-1 medications, not just GLP-1 medications, as we'll get into. There are other ones. And I am joined today by Dr. Lindsay Ogle. So I'll let you introduce yourself.
Hi, everyone. I am Dr. Lindsay Ogle. I'm a board certified family medicine and obesity medicine physician, and I help patients achieve and maintain their health through lifestyle optimization, weight management, and utilization of our safe and effective medications. And I see patients in Missouri. I have a telehealth practice, Missouri Metabolic Health. And in addition to that, I love opportunities like this to spread general medical knowledge because, of course, I'm a doctor, but I'm not your doctor right now. But I can share some of my expertise with you, and you can take it back to, your healthcare provider and find what's best for you and how you can apply it to your health.
I am so excited. Thank you for spending your hour with me and with all of us today. And Dr. Ogle and I connected because we are both involved with the Obesity Action Coalition, which all of you should check out. It's a great organization just to raise awareness of obesity as a disease and kind of break the stigma that obesity is an issue of willpower. Why would we need a board certified obesity medicine physician if it was an issue of willpower? So we'll get into that, but I love that that's how we connected because there is a shared passion in that. Just as some housekeeping before we get into our questions, we're going to kind of go through some common questions. I have these slides, as you can see next to me. I keep pointing the wrong direction. So I'll have the kind of the question up on our slide. We're going to chat. This is our Let's Talk. We're talking obesity medicine, what's changing, because, keep your head on a swivel. There's always things changing in this world, which is exciting, which is great. And then if you have questions come up, use the Q&A box here on Zoom. You are welcome to use the chat, but we may not get your question if you have a question in the chat. So stick your question in the Q&A box and we will go from our pre-organized questions over to the chat box. And that's how we're going to organize it today. So Q&A box is where it's at for that. And we're going to kind of open it up with kind of orienting to this conversation. In your opinion, Dr. Ogle, what do you think with this idea of obesity as a disease? And why would viewing it as a disease change how we treat it and the outcomes?
Yeah, I love that we're starting with this question because I think it really lays the foundation of our approach in the field of obesity medicine. And it wasn't until 2013 that we actually were able to define obesity as a disease and have it recognized as such. And truthfully, that's just what it is. We know that there is underlying physiologic changes that lead to excess weight gain and the persistence of that excess weight. And so identifying it as a disease allows us to talk about it in that way. It allows us to neutralize the condition of having excess weight. It allows us to treat it like any other medical condition, and in such, it opens the doorway for funding and developing, new therapies and eventually getting insurance to cover those treatment plans, just like any other condition. I also think it's really important because it helps us focus on health related outcomes. Anybody who is truly trained in obesity medicine, our goal is not for everybody to get to a certain body weight or BMI or look a certain way. We're really focused on health related outcomes. And weight management is part of that. And so that's why I think it's so important to approach obesity and weight management from that um, standpoint of addressing it as an underlying disease.
Yeah. So with that, like when we think about it as a disease, because I think that's hard for people like, you know, whether we like it or not, the word obesity is really difficult. It's uncomfortable, right? Probably because of even the word obese, like it still makes me cringe. So,
Mhm.
how do we define the disease itself, right? And you kind of touched on that, like body composition, or if we're treating obesity as a disease, like what is the disease, and then how do we assess how the treatment is going? Right? Like how if with this was cancer treatment, right? We might look at XYZ parameters. So what is the disease that we're treating? How
Yeah.
would you describe it?
Great question. And I also sometimes hesitate to use that word, obesity. And I have said before, I wish our specialty had a different name, and maybe the name will change in the future. But right now, that is what we have. Um, so there's different ways, I guess, clinically that we diagnose somebody with the disease of obesity. Immediately we think of BMI, which is an imperfect tool, and really it's best as a screening tool. So, because it's just taking someone's height and weight and putting it into a calculator and putting that number that we get into a category. It does not take into account somebody's age, somebody's sex, their body composition, any of those factors. So it's not as detailed and not as precise. But like I said, it can be a good screening tool, a good place to start. But we have those cutoffs to right now to have that diagnosis. Body composition is getting more and more popular, and for good reason. We know that it's really the relative excess of what we call fat mass versus lean mass. So like the muscle mass in our bones and our organs. We're looking at, how what that percentage is for that person. And if we're able to, get the body composition numbers, and there's different ways that can be done, some more precise than others. But looking at that can give us a lot more information for that individual. And it does take into account at least sex, like female or male, and can help because I guess the thing is with somebody with a certain BMI, we'll say a BMI of 30, somebody could have more muscle or more bone density at that BMI. They're likely going to have less weight related conditions. And so while they may classify as having obesity based on the BMI, from a medical standpoint, their weight is less likely to be negatively impacting their health versus somebody who has that BMI of 30 but has more relative excess body fat, then that is more likely to negatively impact their health. And that is somebody who we are wanting to, treat their obesity, um, in that situation.
Yeah. Yeah, in the location of that body fat, if it's more that visceral fat by the organs and looking at waist circumference. Yeah, and I think for those of you that maybe you have access to body composition skills, maybe you not, maybe you don't. I will put it in our follow-up email, like the same email that you got this link in. I'm getting some emails that people can't find the link. That's the worst. Whenever you start a Zoom call and people are like, I can't find the link. And I'm like, but I'm in the middle of the call. So they will get the replay. But I wrote a blog about body composition, and in that blog, there is a link to a letter that you can advocate for whether you've had bariatric surgery and it's a surgeon's office. Most obesity medicine doctors are offering uh, body composition, but if you have a physician that you would like to advocate that they offer body composition, there's a letter that you can print off and send in, and it kind of helps advocate for using body composition as opposed to just total body weight, just for the reasons that Dr. Ogle described, that it just doesn't tell us enough. It's not enough information. Okay, well, we could talk about that question for a long time. We'll go into the next one and kind of with that in mind, obesity is a disease to be treated. So tell us more about a board certified obesity medicine physician. Like, what does it take to get that credential? Why might someone go to a specialty doctor and how might they find one?
Yeah, so an obesity medicine physician is like we go through traditional training as all physicians do. So we go to medical school for 4 years, and then we went through a residency program. So everyone that is a obesity physician, they have their primary specialty. So for me, that was family medicine. And it's often a primary care specialty like family medicine, pediatrics, OBGYN, internal medicine, but it doesn't have to be. We have obesity medicine physicians who went through surgical training, or some of them emergency medicine, GI specialties. You can go through any specialty. And then after you have that initial training and then your board certification in that primary specialty, after that, you do additional training in the field of obesity medicine. And so often that looks like attending our conferences and doing continuing medical education, just getting that in education on your own. Most people are doing that on their own. There are a few fellowships that are available, and that's becoming more and more popular. But right now, most people are doing that training through mentorship and the conferences. And then you sit for the obesity medicine board certification, and then you have that on top of your initial board. The reason that it is I think it's valuable to find an obesity trained physician is because most other, specialties, we don't get that much dedicated time in weight management and in lifestyle optimization. And so when you find somebody who has taken the extra effort to learn those topics, you know that you're getting somebody who has evidence-based information that they can bring to you. And I may be a little bit biased, but I also think that the doctors and other health professionals that go into obesity medicine tend to be very compassionate and are active listeners and advocates for their patients. And we tend to go the extra mile to write those prior authorizations and appeals to insurance to, make sure that you're getting the care that you deserve. I also want to highlight that we are trained to individualize our approach to each patient. I know there are programs out there who or that have like a set protocol that everybody gets when they join. And an obesity medicine doctor is not going to do that. They are going to hear your whole story, get your whole medical history, and they are going to tailor their approach to you. They know that you've tried lots of things in the past, and we believe you when you say that you are, eating a certain way. We know that it is more than, calories in versus calories out, and we are going to, support you in that journey.
Yeah, and I feel like if nothing else, what I would let everyone to hear is like, if it takes that much additional education, then it's not simple, right? Like it's not an issue of willpower. It's not easy. Like you said, it's not calories in, calories out. Because why would you need to take all this additional certification and take extra boards and all these extra training hours if it was easy? Like every patient's different because every body's different, every genetic situation is different. And that's, I mean, what keeps it exciting. I can honestly say we don't have boring jobs because every single day is going to be different. But it really is not simple. We wouldn't have jobs if it was. Okay, speaking of the medications, will you give us kind of a rundown of the current FDA-approved medications available? I spelled available wrong, but available for obesity treatment.
Yeah, absolutely. So There are several that are available. Obviously, the most common ones that people are aware of right now are the GLP-1s, and the two that are FDA approved. Well, there's three that are FDA approved for obesity. There's liraglutide, which was first approved. That is a daily injection, and then semaglutide, and the brand name that's approved for obesity or weight management is Wegovy. That's a weekly injection, and then Zepbound, kind of our latest iteration, another weekly injection. Some of our quote unquote older medications are phentermine, that's been around for decades now. It's only FDA approved for short-term use, but people who are trained in the obesity medicine field, as long as their state laws allow it, use it for longer term than that, because we know, well, I think we'll get to this later, that we need treatment long term for this chronic condition. There's also Qsymia, which is phentermine and topiramate. So it's a combination medication and on average a little bit more effective than phentermine alone. There's Contrave, which is another combination, and the last three are oral medications. And Contrave is another oral medication that's a combination of bupropion and naltrexone. And then there is Orlistat that's approved as well. It's
Do
not as
you
commonly
ever
used.
prescribe Orlistat?
I've never prescribed it. I included it for, completeness sake, but
It is
I've
FDA
never.
approved. It's not often used.
No, no, it's not.
That one is it helps malabsorb fat is often not very enjoyable for reasons. If anyone remembers the Olean potato chips, that's what I often think of. Do you remember those?
I'm
Is
not
that
familiar.
before your time? There maybe the chat. There we go. I got a laughing emoji. Maybe the chat box can talk about Olean potato chips. It's in that realm of the fat malabsorption. Okay, now let's talk money. We kind of talked on that. Advocacy is big. What we can do. You mentioned, prior authorizations, like, obviously that's one of the biggest conversations is access to care. So if insurance doesn't help with these medications, and I know these numbers too, you probably do too, but what are we talking with the cost of medications these days?
Okay. So the injectables like Wegovy and Zepbound, the sticker price in the US is $1,000 or more, sticker price without insurance. There are more and more programs that are coming available, thankfully so, that are lowering the cost, but it's still cost prohibitive for most people.
About 500 a month. I feel like,
Yeah,
yeah.
500. Lilly Direct for Zepbound, their initial, starting dose is 350, but then
Okay.
the
Then
doses
you
go
go
up
up a dose.
yeah, then go to 500. So that is available direct to consumer, gets mailed to you. And then the liraglutide, the daily injectable on GLP-1, that's still a couple $100s right now. It may become generic next year, so stay on the lookout for that. But with a GoodRx coupon, it's still a few $100s for a month's supply. The oral medications are less expensive, and so that can be a great option if your insurance does not cover these medications, or if you don't have insurance. So phentermine is the least expensive option. It's been around the longest, and with GoodRx coupon, you can get a month supply for $10 to $20 of this medication. For Qsymia and Contrave, they both have like a company program where, again, they mail the medication to you, and it's about $100 a month for those brand name medications. Sometimes obesity medicine doctors and maybe some other primary care doctors will prescribe those individual components because those two are the combination medications. But I often just prescribe like the generic forms of those medications, and then I have patients take the medications together, so it's even less expensive that way. So The oral medications are by far less expensive than the injectables, and hopefully that changes. But right now, that's what we have.
Yeah. So, and feel free for those of you that are taking some of these medications, if you feel comfortable telling us what you're paying, but maybe in that $500 zone at best on for the Wegovy Zepbound. Yeah,
Per month. Yeah, for each month.
for each month. Yeah. Yeah. That's what we're talking here. Okay, and then we're going to segue into compounded medications. Because there's a lot to say here. So let us know. I'll keep an eye on the chat box on the Q&A because I know we'll save Q&A for the end, but I know there's a lot of questions specifically with compounded. And correct me if I'm wrong, but kind of the history here with compounded is I think people get confused that a compound medication is a generic, and it is not. Generic is when a patent expires on a drug, and then basically the market is open and they're allowed to make a generic. But that's not what a compounded medication is. A compound is allowed to be made in the time of a shortage. And Wegovy, or I should say the drug names would be it was
Semaglutide.
semaglutide first, right? And then tirzepatide. During those shortages, those they were allowed to be compounded. And everyone thinks of Ozempic. Ozempic is semaglutide. And that's where we started seeing compounded come out. But that was not a generic. So that's kind of the backstory. But now compound are going away. Do you want to kind of bridge the gap on where they're going or why?
Yeah, absolutely. I feel like most of us did not hear of compounding pharmacies before, the GLP-1s became really popular, but they've been around for a very long time. They were originally, most of them make like dose specific medications for patients who maybe need a dose in between, what is available commercially, or some doctors would order like a lot of times it would be topical treatments that were a combination of active ingredients, and a compounding pharmacy can put that together. Or if somebody has a specific allergy that would be like an additive, maybe in a medication, the compounded pharmacy can work around that. And so that's where compounded pharmacies have been used historically. But yes, they can also make medications when there is a shortage available commercially at our typical FDA-approved pharmacies. And simplistically, they are often described as like generic versions because it has the same active ingredient. It has the semaglutide or tirzepatide, or at least we hope that's what it has, because that's what they say that they have. The issue with compounded pharmacies is that there's not as much regulation, or very little regulation and quality control, measures. And so there were a lot of, case reports and instances where people were getting or ordering their compounded semaglutide, but were actually receiving, a different active ingredient, or there was an additive or something else in there that they were not expecting to have, or the dose was maybe not what it was labeled as, and it was causing a lot of complications, and which is really unfortunate. The positives of the compounded GLP-1s were that they're a lot less expensive than the brand names that we were talking about earlier, and they were available. And so you can't, it's hard to blame anybody for, accessing, that care for this effective treatment, especially if they were able to get it before and then maybe you weren't. And so this could be, an only option. But these medications have been taken off of the drug shortage list. And so it is now I don't know the exact dates actually, but I believe for semaglutide right now it is illegal for any compounded pharmacies to make it. And for tirzepatide, it's going to be in the next
It's a week or two. Yeah.
Yeah, okay. Yeah, I was going to say very soon.
It's really soon. Yeah.
Yeah, where it will be illegal for compounded pharmacies to make this. And it's important to know that because if you are getting advertised on social media, or the place that you're going to is still offering this to you, that is illegal and is a huge red flag. Because if a company is willing to offer something that is not legal, then that they're cutting corners in other ways, and it is not safe for you to continue with that treatment.
Mhm. Yep, that's the truth of the matter. Yes, thank you for sharing that. And it is like, well, I guess I feel like you shared a post recently, like in that situation, if somebody was accessing compounded option, it was in their budget, and now without it, it's no longer in their budget. What would you recommend for that patient?
Yeah, and that's a tricky spot to be in, and I feel for everybody in that situation. Um, there's a few different options, and so of course, talk to your doctor. And I've actually been in a situation where I've seen somebody who was getting compounded medication, and they just went directly there because they thought that was the only option. And come to find out, their insurance actually does pay for their GLP-1. And so you might get a nice surprise there. And maybe all
I
we
think,
need is
yeah.
that prior authorization. So especially if it's been a while since you've looked into your insurance coverage, start there for sure. So if we can get brand name of that medication that's been working for you, that is ideal. Um, for other ways to get the brand name medication, there are some Canadian-based pharmacies. I'm learning about some in the UK that I'm actually, starting to trial with my patients, and so I can report back later if that ends up working out.
Yeah.
So there are some other ways to get the brand name. Um, the Lilly Direct and the Novo Care of getting the brand name medication in the vials. Again, it's still about the $500 mark, which is again cost prohibitive to some people, but less than the sticker price at the pharmacy. Um, and then there are people who maybe you are in your maintenance phase of weight management, and it is possible we could transition to one of our oral medication options, and that may be sufficient for your weight management, stage. And so that could be something to consider. And then there definitely is bariatric surgery. I think that has been overlooked in the height of our GLP-1 medications, and bariatric surgery for many people is a great option. It's still our most effective option that we have. And a lot of times insurance will cover that, even if they won't cover the medications. And I also like to remind people, even if you have to pay, even if your insurance does not cover bariatric surgery, it's important to think about the long-term cost of the medication that you're paying for, because that's a monthly cost that we are needing to continue long-term. Whereas on bariatric surgery, it's usually they have like if you're paying out of pocket, there are lumps some costs, and oftentimes they have payment programs and things like that. So that's another option to consider. And I always highlight too that the work that you've done is not erased. If you have to stop a medication, you have done amazing things for your health. You have gotten into these great habits and routines, and it is important to continue them. And I know mentally it can be really difficult. It can be devastating to lose, that medication that was working so well for you, but you can continue. You are strong enough, you can continue, moving forward. And that may involve working with a dietitian or a coach or a therapist or a trainer or an obesity medicine physician. Build a team around you to support you during this transition.
Great feedback. Yeah, and I am comfortable telling you all that I use Qsymia to manage obesity and have had I mean, it controls appetite. All the things that I do to manage with protein and fiber and water and activity in Qsymia, and it's really helpful for me. So I'm happy to talk about that anytime as well.
Yeah,
Um, Yeah.
The weight loss we see with Qsymia is pretty close to semaglutide for some people. It averages like almost 15% body weight loss. It's not talked about as much
Yeah.
because it's not as exciting for some reason, but it can be really, really effective.
Yeah. So that's certainly like, that's what that one, and you said that one is one of those dual drugs that could be prescribed generic, but in a combo but it's usually around the $100 or it could be less.
Yes, yeah. So your insurance may cover it. If it doesn't, you can definitely get a coupon. Just like if you Google Qsymia coupon, you
Yeah.
would find it. And then they have their own program where the doctor could, I think they just have to fax the order to them or email it, and then they'll send you the medication to your home. And that's I looked yesterday. I think it was $99 or $98, something like
Yeah.
that.
All right. Well, we have just a few questions left here and then we'll go to Q&A, but I think we've touched on some of these, which is wonderful. Um, we'll keep on going through here. So are these medications forever? Can you wean off them and maintain results? I know we've kind of touched on this, but we'll go ahead and face on answer it.
Yes. So for the majority of people, yes, these medications need to be used long term. Obesity is a chronic multifactorial disease, and like any chronic medical condition, whatever we're doing to manage that condition, we're going to have to continue long term. And so my go-to example is high blood pressure. And so when someone has high blood pressure and you're started on a medication, the blood pressure is controlled while you're on the medication. And then if you, for some reason, stop taking that, the blood pressure goes back up. And truly the same thing is for obesity. If you are on your medication and it's suppressing your hunger, it's helping with fullness. If you stop the medication, then the hunger is going to come back. You're not going to feel as full with smaller portions. And it to me, that just tells us how much the medications work because they are working when you're taking them, and then when you're not taking them, it's out of your system. The caveat I would say would be for somebody who maybe has not had obesity, long term, or they probably don't technically have like, the disease of obesity. They have had something in their life that led to temporary weight gain. And common examples could be like a medication that we needed to use, but that led to weight gain, or postpartum period for women, or a depressive episode and somebody was overeating when their depression was not treated. We may use medications temporarily in those situations that can help people get back to their previous weight set point, and then they may be able to wean off of the medication and maintain their weight loss after that. But for most people, long term is the most effective.
And we kind of touched on this as well. But I think this is a question. I mean, I know a lot of my audience has already had a bariatric surgery. So the next question will be maybe when to consider a medication post-operatively. But I think this question does kind of come up, which is natural, like if medication was an option when I was thinking about surgery, like maybe I wouldn't have had surgery, but maybe that's just kind of like at what point, if someone's pursuing treatment for the disease of obesity, would you talk through a surgical treatment versus a medication treatment? And you kind of touched on that, like looking at the medicine or looking at each individual situation. But do you have kind of like like a fork in the road of a surgical versus a medical?
Yeah, it is so hard to say because it really is truly individualized. Part of it, or a huge part of it, is patient preference, and so some people are really, adverse to, wanting to do a surgery, and that's fine, and we can utilize our medications. But if somebody has, a lot of weight to lose, then maybe the medications will take us to a certain point in our journey. And then after that, if we're still not at our health goals, then maybe that would be time to consider, surgery at that point. I've also seen medications used to help with aid with some weight loss prior to surgery to allow the surgery to be a safer procedure at that point. Um, we talked about costs. Sometimes insurance covers surgery and not medication, so that could be a time to lean more towards it. I also think about patients who have difficult to control diabetes. Bariatric surgery, specifically Roux-en-Y gastric bypass, is very effective at co-treating both obesity and type 2 diabetes. And for a lot of people, can put their diabetes into remission. And so that's a patient that I may encourage to consider bariatric surgery if their diabetes is difficult to control. And then we can use medications after, which, like I said, we're going to talk about here soon.
Yeah, I'll pop up our next question. Segue it so nicely.
Yeah,
If that medication be utilized after surgery. I know, just in my experience, each clinic is a little different and each, patient's going to be different. But I feel like as a standard, a lot of programs will say, maybe not in the first 12 months post-operatively, just because that is a rapid time of weight loss, the honeymoon year, allowing the surgical treatment to see how the body's going to respond to that. But if it's been more than a year and there's prolonged weight plateau or weight reoccurrence. So that's what I hear kind of on the surgical side. What would you say?
yeah, I would totally agree with that. I would, yeah, I would not feel comfortable using medications prior to a year post-op. Um, and like you mentioned the weight plateau, that would be a great time to add in a medication, weight regain, or even if somebody is really battling if they still have a lot of food noise and a lot of hunger after surgery, we can use our medications to help with that. And that might be a great time to use our oral medications because a lot of them really do help with the food noise and hunger and not impacting the GI tract as much. And so that could be a benefit with some of those other medications. Um, and I did think of another time to maybe lean towards surgery rather than medications, is if you have contraindications to the medication. So there are reasons that we can't use each of our medications for obesity. And so if you have those reasons why you can't take the medication or you've tried them and you can't tolerate it, then that would be a time to really consider, surgery rather than the medications.
Absolutely. Okay. Any known long-term effects of medications?
Yeah, so most of the side effects that we see with these medications are short term, which is great because we can identify them early and help manage them. The GLP-1 medications, while they're newly approved for the disease of obesity, they've been utilized for type 2 diabetes. They've been on the market for 20 years. The first GLP-1 was FDA approved in 2005. And so they've been in clinical practice and then for 20 years and studied even prior to that. So we have at least 20 years of real world data to show that they are safe. Um, the concern we hear the most about is thyroid cancer or cancers in general. That was really seen in our animal studies, our rodent studies, and have not been proven in human studies or clinical practice, as of now. It's something we're actively and always monitoring. And we have the black box warning with a family history of medullary thyroid cancer, and it's only medullary, which is a less common or one of the least common forms of thyroid cancer. So that is the one major thing to watch for, and it may not even be a true concern that we have. But most of the side effects we see when we start it or when we're increasing the dose, and there's lots of things that we can do to help control those side effects.
Yeah, I spent a lot of my time talking about managing symptoms through nutrition and food timing, and usually it can be managed well with some tweaks.
Yeah.
And I saw a question, and that we're going to move over to Q&A here in a moment too, but this one popped up, so we'll cover it here. Is the point of a GLP-1 to quiet the food noise? Somebody asked what food noise is. So quiet food noise slash what is that? To not be hungry, to be too sick to eat. So maybe the underlying question here is like, what is it doing? Why is it
Yeah.
so powerful?
So the point of these medications, of any of the we call them anti-obesity medications, is to correct the underlying um, pathophysiology, what's happening in the body that is leading to the weight gain. So it is not, the point is not to make you sick. People are not losing weight because they're, vomiting or anything like that. This is actually brought up in the obesity conference I went to a couple of weeks ago. Our new president, Dr. Bays, he does a lot of clinical research, and he was talking about a medication that they were trying to develop years ago, and it didn't, go through all the way, but it did cause a lot of nausea and vomiting, and people actually didn't lose weight on that medication. So we know it's definitely something else that's coming here. I say the reason that the GLP-1s are so powerful, how I describe it to my patients, is they really work in three different ways. One is it's blocking the hunger signals to the brain. The food noise that people are talking about is a lot. There are people who are constantly thinking about food. So when you're at work, you're distracted because you're thinking about what am I going to have for lunch, or what is there at home to make for dinner, or when you're going to bed, thinking about what you're going to have for breakfast the next morning. It just is consuming and takes a lot of brain energy to manage those thoughts about food constantly. And so this helps to block some of that food noise and those hunger signals. Um, it also helps slow food through the GI tract. And this is where we see some of the side effects that are common with it. But the way that it helps with weight management is because food is staying in the stomach for a longer period of time. You feel full for longer periods, and you're able to feel full like in between meals. And it helps with portion control in that way. And then the third is it helps stabilize blood sugar and insulin levels. And that's where it was, initially designed for the management of type 2 diabetes. But it can help with weight management because insulin plays a role in weight regulation. And so if we're able to stabilize that level over time, that can help the body release some of the excess weight or energy stores that it has. And it also helps, prevents those blood sugar crashes after meals, like the blood sugar going high and low. That can affect, some of the foods that we're craving. And so because it works in three different ways, whereas some of our other medications really would focus kind of on one way that they would help with weight management, that's why this is helpful for, I think, it seems like a broader set of patients. And it tends to, on average, have more weight loss compared to our other options.
And then there's some more coming. So with more in the FDA trials, what do you think we'll see in the future of obesity medications? Did they talk about this at the conference?
They did, and there's a lot, way more
A
than I
lot.
even was aware of. And then there are some they're saying that are like even earlier on and that they didn't include. Um, we're seeing a lot of combination treatments. So like tirzepatide is GLP-1 and GIP. So we're going to expect to see many more like reiterations of that are using different oftentimes gut hormones, but maybe other mechanisms as well. So a combination treatment, again, leading to what we would expect to be more effective treatment options. And there's others there, they're working on making sure that everything is safe and effective prior to approving. And we're seeing that not only are medications needing to show, treatment of obesity and weight loss and weight management, but we're seeing other health outcomes as well. So we're seeing, decreasing cardiovascular disease risk, decreased cancer risk, improvement in, fatty liver disease. We're seeing other benefits with these medications, which is really exciting. And as we get more FDA approval for those different indications, hopefully that will then lead to more insurance approval as well.
Yeah, it's like we have to see those other conditions to then see more access, even though the root of it is often the obesity. If we gave it obesity approval, instead we're like going for each of these individual things, which oftentimes obesity is the root of it. Yeah, I've heard there's a oral GLP-1 that's in just started stage 3 FDA trial, although stage 3 is the longest. But instead of the injection GLP-1, there's also one that they're hoping would maintain lean mass so that it would target more of the body fat, obesity, disease of fat, but maintain lean mass. But yeah, there's a lot. And like you can't really keep up. So we'll see what makes it to the end and then we'll keep up, right?
Yeah, yeah, that was kind of their summary. They're like, it's impossible to keep up. There's
Yeah,
so much
you
going
can't know.
on.
Okay, well, I'm gonna head over to the chat box. We've got about 15 minutes left, and I'll hit on as many as I can. I know some of them we've touched on, and I'll just go in order. Okay, with Saxenda coming off of patent, do you expect to see its use surge?
Yes, I have heard that with the cost going down, that might be the go-to or something that you could transition to for a more affordable option.
And how I have heard that a patent can be like 20 years. Does that sound right to you? Do you know the timelines?
I thought it was 10,
Okay, maybe I'm over it. Or
but
sometimes they can extend it, maybe.
yes,
Okay.
exactly. Mhm.
How does menopause play into weight gain and obesity?
Oh, great question. This is a hot topic. So there's different factors, but one of them is, of course, a change in estrogen levels, and that can lead to increased insulin resistance. And as I mentioned earlier, insulin affects our weight regulation. And when we have insulin resistance going on, our pancreas has to release more insulin to overcome that resistance. And the reason that's happening is to help control our blood sugar. So that's the primary, reason for insulin. But insulin is a storage hormone. So when those levels are high, it's telling our body we have a lot of energy stores. We can then save that for later. And so our body's going to hold on to the extra calories, the extra energy as in our fat cells. And it tends to, during that time, predominate like the fat gets placed around our abdomen. And so that's where we see a lot of the weight gain is in the belly area during this period of time. And so it's extremely frustrating for women to be doing what they've always been doing. And all of a sudden, you're going through menopause and you are gaining weight when you used to maintain it, with your regular routine. And nothing's changed other than the underlying, physiology during menopause. So that plays a role. One would think that then replacing the estrogen with hormone replacement therapy would lead to, weight loss. Unfortunately, that's not the case. Hormone replacement therapy can help with the other symptoms of menopause and can help with energy and help with sleep. And if you're having hot flashes and things like that, that can, allow you to continue to have those healthy habits. But it hasn't been shown to lead to weight loss. Many people are utilizing the GLP-1 medications during this time and are having great success. And so that can be an option. We sometimes use metformin, kind of off label. Some people use this for insulin resistance that may be able to help kind of nudge your physiology back to where it was before. So those are some options, that I think of during this time.
Another great example of how none of it's simple. It's also so much more complicated than meets the eye. Are the oral medications as effective as the injections?
So also not not as simple.
I know, not straightforward.
Yeah, it depends. So on average, no, except Qsymia gets really close to semaglutide or Wegovy. Um, I This is another thing that really, really interests me is obesity phenotypes, which is like a reason why somebody has the disease of obesity. And I actually just did a YouTube video about the four phenotypes and did some posts on Instagram and TikTok about them because and there it's interesting, there's a genetic test now for it, which I've never ordered, but that is available. But often you can kind of tease out based on, your presentation, and especially with working with an obesity doctor to help tease that out. But what they've proven is based on your phenotype, you're going to respond to the treatment differently. And what was really interesting was when they matched somebody's phenotype with their treatment plan, they saw a huge gap in how they respond, even with the GLP-1s. And so if somebody, we don't have time to get into all the phenotypes, but hungry gut is the one that was best suited for GLP-1s. And people who had hungry gut and were on a GLP-1 lost more than people who did not have hungry gut. Maybe they had another one is called hungry brain. Those people do better on phentermine or Qsymia. And so they are actually able to show those differences. And so we have our averages and we can look at that, but you as an individual are going to respond to treatment differently than the averages. And that's why we have some people who again, even just for the GLP-1s, we'll say that the semaglutide average weight loss is 15% body weight. There are some people in the trials that only lost 5% of their body weight. And then there are people who lost 20% or more. And there's that whole range. And I think a big part of that is in their underlying phenotype. And if you're able to get matched, then you're probably going to respond better to the treatment.
That's fascinating. I will definitely link your video in our follow-up email. I'll have to go watch that. Is Qsymia long-acting or slow release?
Oh, that's a good question. It's
It's pretty quick. It's pretty quick.
yeah,
Yeah.
yeah.
Because it leaves the systems pretty quick.
Yeah, I often do the separate versions, like I
Yeah.
said.
Okay. If it's long acting, okay. Do you find that it work? I think this is a follow-up to that same question. Do you find it works differently than when prescribing generic topiramate and phentermine together?
Mm, mm. I don't know if that's ever been trialed,
Yeah.
or compared, but I guess I would lean towards thinking probably the brand name is maybe a little bit better, because there's those exact dosages. But if cost is if it's difficult to afford the brand name, then the generic is great. And I have patients who respond really, really well. If you've gotten to a certain point on the generic like combination and you still have more to get to your goal, then it may be worth trying the brand name and seeing if you are responding, getting that little bit more benefit from it.
Okay, there is a question. Are there oral options of GLP-1? So not yet. That was one that we mentioned is an FDA trials, but currently FDA-approved GLP-1 medication is an injection.
Mhm.
I'm gonna
There, the
go ahead.
the semaglutide, there is an oral version for diabetes called Rybelsus that could be used off label
Oh yeah.
for obesity, and it's been tested like much higher levels than it is proved for type 2 diabetes. I don't see a lot of people doing it. I think I've had one patient, maybe two in my practice who have gone down that path because it's still fairly expensive. Um,
Okay.
And in the injectables, truly the needle is like so tiny. It just goes right under the skin. So if somebody's, has a fear of needles, I try to, I don't want that to be a reason not to try the injectables and going to the orals.
Okay, I'm glad you answered that more fully than mine. That was great. I have been on a compounded semaglutide for over a year now, have found a lot of success after having gastric sleeve in 2021. I've also recently been taking Vyvanse for ADHD, and I found the combination to be too much and difficult to eat. Would something like Qsymia be a good option for me to go instead? I'm currently weaning off semaglutide.
Mm. Yeah. Well, I'm glad to hear that you're weaning off of the semaglutide. I think that that's going to help with the best results. I probably wouldn't do if you're going to continue the Vyvanse. I wouldn't do Qsymia on top of that. That would be too stimulant because phentermine is a stimulant. Um,
Mhm.
so that would probably be too much. But if you were wanting to, talk to your doctor about switching from Vyvanse to Qsymia and seeing if that is like going to help all of your conditions in one medication, then that is a great option to consider.
My good friend Hannah, I said Hannah, and my good friend, and I mispronounced her name, Anna. So she's family medicine PCP. She says, I get asked about and talk about obesity management daily. What can we do to help advocate for coverage when PA and appeals are denied? What's the outlook on insurance coverage widening for GLP-1 RA? What are good places in the Kansas City metro area? Oh, I can help with that one to refer for obesity management if patients want more specialty care. So I can answer the Kansas City piece.
Oh,
Uh,
great.
yeah.
Um, so if somebody is getting their insurance through their employer, it's actually best for either them and I know that there are ref or resources where and I don't know if Steph you have this available with for like letters for patients to give to their human resources department. I think the
Yeah,
Obesity Action Coalition may have those
they might have that.
because it is actually the employer's choice to include that coverage or not. And many people don't know that. And so if an insurance I guess, program or plan does not cover medications for obesity, there's honestly at that point not much we can do, but an employer could choose to add that on to their benefit. And there was just an article that was released that people are changing jobs to employers who offer that benefit. So it's going to be of their the employer's benefit to include it because they're going to be able to keep, their employees that they have. So that would be a place to advocate for. Um, and then being a part of the Obesity Action Coalition and signing petitions that they have and just being a member will help support the community as well.
Yeah. Yeah, we only have a couple minutes, but so I won't get too far into it. But there was a proposed rule that did not get approved that for Medicare recipients to have anti-obesity medications covered, but it did give us, I say us advocates, more opportunity to have more meetings. So I'm a part of an advocacy team. I'll be in DC. So we just keep those conversations going. And I don't think I think that the conversations are still happening. So that particular rule did not happen, but I think there's ongoing conversations of how we might have some legislation because if we can get some coverage with Medicare and CMS, then private insurance typically follows that. But as we know, there's a lot there. Okay, a couple questions that I'll try to answer. Any other questions that we didn't get, I will have our contact information in the follow-up email. Again, Dr. Ogle owns Missouri Metabolic Health, and she can see patients in Missouri, and you could follow her on Instagram and YouTube. I'll put all of that online. Anything else as far as how people can follow you or any
Uh,
other final words before I hit a couple of these questions?
no, just thank you for allowing me to share this information. It's great to get it out there.
Thank you for being here. I'm so grateful for your time. Um, Couple questions that I can answer really quickly, and I'll get you the Kansas City contacts. Suzanne, I'm pretty sure that's my mother. Hi, Mom. Do you think patients on weight loss medication should be screened for nutrition deficiencies? Yes. Did you cue that up for me, Mom? Yes, there is not only screening that we do in lab work, so annual lab work. Certainly, if you've had bariatric surgery, you are going to have labs done there, and you can speak to labs. But if you are working with a dietitian that is familiar with a nutritional screening, then we do know how to do that in terms of our visual um, cues and things that we can also look for outside of labs. So there, if you're working with a comprehensive care team, a dietitian, physicians, then nutrition deficiencies are going to be much more likely to be caught. Um, and you're supplementing in advance. There is, when it's a little more DIY, you're going online, you're not working with as, more of a comprehensive team, it is easier for those things to slip through the cracks. Anything else you want to speak to with deficiencies?
Um, No, I agree. I think working, with an individual, the dietitian, with, your physician is the best approach. And following up regularly, I know a lot of people can get lost to follow up, and so it's really important to stay in contact with your providers.
All right. Okay, any other questions, feel free to send them our way, and I will wrap us up for today. I do have a course, What to Eat on a GLP-1. If you need food help, I'm your girl. I'll put that in the follow-up. If you are a Premier Access member, you already have access to that course. It's in the library. If you're not a member, you can join and get that course, or that course is available as a standalone course. So if you don't need all the bariatric nutrition information, but you do want help with GLP-1 eating, you can do that. Or I can see patients one-on-one in certain states. So again, follow-up email will have all that info. And thanks again for joining us. Have a great rest of your Tuesday.
Thanks,
Bye.
everybody. Bye.